Can blood tests and imaging help predict who will develop memory loss? Is it safe to skip CT scans in some patients with cancer and suspected pulmonary embolism? Why are self-collected HPV testing options getting so much attention? Are these self-collected samples just as good as a clinical test? This and much more on today's JAMA Editor's Summary. Hello, and welcome to our listeners around the world. Today is July 17th, 2026. I'm Dr. Kirsten Bibbins-Domingo, Editor-in-Chief of JAMA and the JAMA Network. Today I'm joined by Dr. Preeti Malani, JAMA Deputy Editor. Let's get to what's new in clinical research this week.
Thanks, Kirsten. Our first article is on a topic relevant to many clinicians, patients with cancer who present with suspected pulmonary embolism, or PE. This group of patients are at high risk for PE and are often sent straight to CT pulmonary angiography with the associated radiation, contrast exposure, and cost. Dr. Ackerboom and colleagues ran a multi-center, randomized, non-inferiority trial to see if the years algorithm, a decision rule that uses 3 clinical items and a D-dimer threshold, can safely avoid CT scans in some patients. They randomly assigned almost 700 patients with active cancer to evaluation either with the years algorithm or default CT scan at 21 hospitals in 6 countries. The investigators report that among those with PE excluded at baseline, 1.8% of the years group participants suffered venous thromboembolism or PE-related death within 90 days, compared with 5.5% in the CT-only group, which was the primary outcome. So fewer events in the years algorithm group, not more. And 22% of patients in the years group avoided a CT scan altogether. The bottom line, in this high-risk cancer population, using the years diagnostic algorithm was as safe as sending everyone to CT pulmonary angiography, and it obviated the need for a scan in roughly 1 in 5 patients.
In an accompanying editorial, Drs. Hahn and Beckman point out that although the years pathway won't be more accurate than CT pulmonary angiography itself, this trial is a real advance. The editorialists caution about generalizing until we have more cancer-type specific data and suggest that future studies explore tailored D-dimer thresholds in cancer subpopulations. But for now, it appears that clinicians have evidence that systematic decision tools can safely reduce imaging in select patients where PE is suspected.
Well, Kirsten, we have 4 papers this week publishing simultaneously with the Alzheimer Association International Conference. The first study focuses on hyperphosphorylated tau as a tempting treatment target. Dr. Fleischer and team ran a phase 2 trial of Ceperognastat, a potent oral OGA inhibitor designed to slow tau aggregation. OGA stands for O-linked N-acetylglucosaminidase, an enzyme with many roles in the body. But in the brain, OGA essentially makes tau less soluble. The idea here, based on some animal models, is to inhibit OGA, thereby improving tau solubility and reducing tau aggregation and neuronal loss. In this study, the investigators randomly assigned participants with early symptomatic Alzheimer disease and biomarker evidence of tau to either 2 doses of Ceperognastat or placebo, treating for about 2 years. When they measured disease progression, they found no sign that Ceperognastat slowed decline. In fact, the higher dose group seemed to decline faster on cognitive and functional scales. Although the treatment group showed benefit in several non-clinical secondary outcomes, less brain volume loss, slightly slowed regional tau accumulation, and reduced Alzheimer-associated plasma biomarkers, the significance of these findings is unclear. So the take-home, OGA inhibition with Ceperognastat did not slow progression of early symptomatic Alzheimer disease. It may have even accelerated the condition at higher doses and was associated with more adverse events, especially at the higher dose.
An accompanying editorial by Drs. Rabinovich and Grill reminds us that negative trials can still move a field forward. The authors call out the curious disconnect between biomarker findings and clinical worsening, and they urge caution before relying on biomarker endpoints alone as proof of disease modification. Until we have surrogate markers that truly track patient outcomes, these authors remind us that clinical benefit should remain the gold standard. Moving on to the next new Alzheimer's study, an individual participant data meta-analysis on Alzheimer's disease diagnostics. Dr. Blazanets and the Centiloid study group combined more than 49,000 PET scans from 53 cohorts worldwide. Their goal was to quantify Centiloid cutoffs for a positive amyloid scan. As a quick refresher on Centiloids, think of it as a metric measured from 0 to 100 to quantify PET signal correlated with the presence and density of amyloid. This study found a cutoff for amyloid positivity around 18 to 20 Centiloids when using data-driven methods and 23 to 27 Centiloids for visual read approaches. The authors propose combining these findings into a double cutoff approach. That is, scans under 11 Centiloids are very likely negative, scans above 26 are very likely positive, and scans in the 11 to 26 range are in an indeterminate gray zone. In this study, across cohorts of diverse participants, the Centiloid scale proved reliable, and the authors emphasized caution when interpreting results in the indeterminate zone of 11 to 26 Centiloids.
In an accompanying editorial, Dr. Nasrallah and Brown explained that these findings offer much-needed clarity for clinicians and researchers using the Centiloid scale. They advise that local calibration remains important and that cases falling in the indeterminate zone warrant particular attention, potentially combining quantitative and visual readings or additional biomarker testing. In another new article on the topic of cognitive impairment, Dr. Buckley and colleagues pooled data from 6 major observational and trial cohorts, including more than 2,600 people who were cognitively normal at baseline, all with plasma P-Tau217 measurements. They found that higher plasma P-Tau217 at baseline corresponded to a much higher risk of developing clinical cognitive impairment. In their data, those with very high P-Tau217 levels had about a 38% absolute risk of progression to impairment within 5 years, compared with just 12% for those with low levels. Even after adjusting for amyloid PET results, P-Tau217 added strong independent prognostic value. These risk estimates are crucial for designing prevention trials and, down the road, could help shape risk scores and how we talk to patients and their families about individualized risk. But for now, the authors emphasize that these models need further validation.
The accompanying editorial by Drs. Schindler and Wolk notes that the ability to provide time-specific absolute risk numbers moves us closer to individual risk counseling in preclinical Alzheimer's disease. But these group-based estimates shouldn't be used for individual predictions in the clinic yet. More generalizable data and better integration of other risk factors are needed before broad implementation.
And the final article on the topic of Alzheimer's disease explores what amyloid clearance actually looks like in the human brain after treatment. Dr. Brown and colleagues present a unique case study of a patient with cognitive impairment and a high-risk TREM2 variant who received extended doses of aducanumab, a monoclonal antibody targeting aggregated forms of amyloid. Autopsy findings for this patient included abnormalities in some brain regions, particularly the gyral crest, that had almost no residual amyloid, whereas other regions, for example the sulcal depths, retained plaques. Those cleared areas also had less tau pathology and slower atrophy on imaging. The authors suggest that thorough transcortical amyloid clearance may be necessary to see meaningful downstream effects. Although these findings are from a single patient, the pathology findings raise key questions about why some brain regions may have more efficient clearance and how that might influence disease progression.
With tens of millions of people worldwide affected by Alzheimer's disease, it's great to see robust scholarship in this incredibly active area of research. Shifting away from Alzheimer's disease, our final article is a research letter about prescription drug costs and the new Medicaid generous payment model. Drs. Huang and colleagues analyzed the likely impact of this new payment model, which ties drug prices to the lowest price paid in 8 other high-income countries. They evaluated 82 high-cost brand drugs and estimated that most would be priced lower with the policy than current U.S. Medicaid net prices. Extrapolating, they estimate $8.6 billion in annual savings for Medicaid, almost 35% of net Medicaid spending on these drugs, with over 90% of the saving coming from companies who've already agreed to participate. The biggest impact would be in states that currently have limited leverage for supplemental rebates. The policy wouldn't affect cost sharing for Medicaid beneficiaries. It does have some caveats, mainly the risk of manufacturers gaming international pricing or delaying launches abroad. Still, this is a potentially significant tool for U.S. drug spending and one to keep an eye on during its 5-year pilot period.
While that rounds out our research articles, let's take a look at some of the new viewpoint pieces for this week. First up, Drs. Racine and Gruber warned that deep cuts to Medicaid, even when aimed at adults, end up restricting coverage for millions of children. The authors emphasize that Medicaid serves both as a safety net and a long-term economic investment for all U.S. children, and cutting Medicaid will have broad negative consequences for health, educational attainment, and the overall fiscal future.
In another new viewpoint, Professors Huberfeld and Haupt discuss recent Supreme Court decisions that, in their view, weaken the ability of states to uphold evidence-based medical standards. They see growing First Amendment protections for substandard or unlicensed care as an emerging threat to both consumer protection and the public's trust in the medical profession. We also have a new JAMA guide to statistics and methods. Dr. Belinsky and colleagues review the basics of difference in difference analyses and their use for estimating intervention effects in non-randomized settings. This is the first in a series of articles that are a follow-up to a special communications JAMA published in 2024 that is a framework for developing causal inference from observational studies. In this series, the authors discuss how investigators might apply this framework for specific study types. Here are a few key points from this new JAMA guide to statistics and methods. The difference in difference method adjusts for baseline differences and common changes over time, but relies heavily on the parallel trends assumption. Investigators should select a good comparison group and check for parallel pre-intervention trends. These steps are crucial for robust inference. Using regression models allows analysis for more complex situations, and results should always be interpreted in the context of sensitivity and placebo tests. And limitations arise when there are unmeasured confounders or policy changes affecting groups differently over time.
In their editor's note, JAMA statistical editor Dr. Issa Dehabre and JAMA senior statistical editor Dr. Roger Lewis clarify that reports of difference in difference studies must be careful with language and transparent about assumptions. They note that a causal interpretation, especially in observational studies, requires more than just the right statistical model. It needs careful discussion of identification strategies, parallel trends, and sensitivity checks.
All right. As we start wrapping things up, let's close with a JAMA review on hip fracture, a JAMA clinical synopsis, as well as some clinical pearls for clinicians and patients. Hip fracture is a major cause of mortality and disability in older adults. This JAMA review by Dr. Johannes Dottir and colleagues offers a comprehensive update. Here are some key takeaways. Hip fractures in older adults lead to high one-year mortality, about 22% overall, and can lead to long-term functional decline. Risk factors include older age, female sex, low bone mineral density, previous fracture, poor muscle strength, and certain medications. Management includes early surgical repair, rehabilitation, fall prevention, and for many patients, anti-resorptive medications such as bisphosphonates or denosumab, especially for those with vertebral osteoporosis or very low bone density. Immediate attention to modifiable fall risks and secondary prevention after a hip fracture can make a meaningful difference in outcomes. This review has some great illustrations on fracture types, as well as a nice summary table with the latest on who to screen for hip fracture risk and how to do it.
Also, be sure to check out this week's JAMA Clinical Reviews podcast featuring JAMA Review author Dr. Keel and JAMA Deputy Editor Dr. Mary McDermott. They discussed this hip fracture review further. Here's a bit of their discussion.
I think one of the most important things is to get patients up and walking, because weight-bearing activity is good for the skeleton. The skeleton can sense loading, activity, physical activity, and so walking and exercising is one of the most important things. Nutritional factors are also important. Protein intake is often inadequate in very old adults who have a limited dietary selection. So ensuring good protein intake and good caloric intake, along with exercise and the prescription medications, are very important.
The new JAMA clinical guideline synopsis is on HPV screening and self-collected vaginal samples. Clinician-collected cervical samples remain optimal for HPV screening, although self-collected vaginal samples using PCR-based tests are now considered acceptable for routine screening in average-risk individuals. Here are some of the key points. Negative results on self-collected swabs should be followed with retesting in 3 years. If HPV-16 or HPV-18 is detected, colposcopy is recommended. Other high-risk subtypes of HPV should prompt reflex cytology. Self-collected swabs increase screening participation and perform similarly to clinician-collected samples in terms of accuracy. Access to confirmatory testing and specialty care remains essential for those who self-screen positive. A new JAMA patient page talks about pre-pregnancy care and the importance of optimizing health for anyone planning a pregnancy. Here are some quick takeaways. All reproductive age individuals should discuss their reproductive plans with their clinician. Screening for infections like syphilis and HIV, discussing substance use, and providing recommended vaccinations are key steps. Everyone planning a pregnancy should receive folic acid and work on optimal chronic disease management. For those not planning pregnancy, effective contraception counseling is equally important. Well, that's a wrap for this week's JAMA Editor Summary. If you want to stay on top of the latest medical news, check out one of our other podcasts, the JAMA Medical News Podcast, publishing every Friday with insights into the biggest stories in health and medicine. You can subscribe at jamamedicalnews.com or click on the link in this episode's show notes.
Thanks, Preeti, and thanks to our listeners for tuning in to hear what's new at JAMA this week. This episode was produced by Shelley Steffens and Dr. Michael Lipnick at the JAMA Network. A link to this JAMA content can be found in this episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thank you for listening.
The script for this podcast was generated with assistance from GPT 4.1 OpenAI tools following an editor-developed prompt. The script was then reviewed, edited, and approved by editorial staff. This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.